was pointed out to me by Linda Celine today that 10 years ago, I taught my first course here at this facility in one of the very first spine program here. So it's been an interesting decade. These are my disclosures. I was paid $75 for a textbook in the last couple of years. One of the disclosures is pertinent. As of May of this year, I became a consultant to SI Bone. And so a lot of the information involves information that is company-sponsored clinical trials. And so we'll go through that. All of the information is public domain. All right, so I like the concept of the bottom line up front. So what's the bottom line up front about the SI joint? Well, it moves a little bit. It is innervated. There are specific physical exam maneuvers that you can do to reproduce the pain. Image-guided local anesthetic injections can relieve the pain. There's limited low-quality data evidence on non-operative treatment, and there's emerging more and more high-quality evidence on surgical treatment. So is this a hot topic? Well, how do we decide if something's a hot topic or not? Well, let's start by doing a PubMed search. And you can see that if you look at how many articles are published on the SI joint, it's continuing to increase. And if we do the same thing for SI fusion, we see the same thing. And another way to assess interest in the community is how much money is being put in by investors in trying to develop products. And so there are somewhere in the 27 or 28 product ranges for these implants. So is SI joint pain a problem? Well, is low back pain a problem? Well, it's the number 2 reason that people go to see a doctor in the United States today. Anybody know what number 1 is? Upper respiratory tract infections. So, and of the people who come with low back pain, 15 to 30% of them are actually SI joint. Non-operative care is expensive because it's a recurring expense and has low levels of evidence, and it's also low risk. And it turns out that SI joint problems are very debilitating. So what's the data behind the prevalence? So there are multiple studies showing that there is a 15 to 30% in people with primary low back pain. In people who've had spinal fusions to the sacrum, the incidence is actually higher. So how did I get started in this? A number of years ago in my clinic, about 2007, we decided to look up the patients who were referred to me for back pain to a spine clinic and see what their diagnoses were. Now, 200 consecutive patients, none of them had surgery on their hip, spine, or SI joint, and then this was the breakdown. So you would think they would all have spine pain. Well, no, they didn't. Some had hip, some had SI, and some lucky people had all 3. If you are going to play in this space, you need to understand the differential diagnosis. And the differential diagnosis of SI pain is actually fairly extensive. Basically, what anatomic structures are in that area, and can they hurt? Yeah, most of them can. And so you need to at least think about these in your differential process. How disabling is SI joint pain? Well, every health condition can be rated on what's called a quality-adjusted life year scale. So perfect health is a 1.0 and death is a 0. And every condition can be rated somewhere in that scheme. And you can see that the SI patients are somewhere around a 0.5, which is actually pretty debilitated. And to put that in context to things that we know, it's the same amount of disability as people who need a total hip, a total knee, surgery for lumbar stenosis, degenerative spondylolisthesis. So that's the degree of disability that can exist with the SI joint. How much does it move? Well, there have been several different ways of looking at this. Röntgen stereophotogrammetric analysis, which I have to read because it's trying to say it is just kind of tough. So RSA has been done in Sweden and looked at this in actual living patients and showed about 2.5 degrees or 0.7 millimeters. It's done with 2 radiographic sources simultaneously, and they implanted tantalum balls in the patient's sacrum and in their ilium. And then other strategies of looking at it have included electrogoniometers placed on the patients externally, CT scans where they manipulate them, and they all come up with the same kind of answer. Doesn't move a lot, but it moves a little bit. How does the SI joint function? Well, it's a combination of what we call form and force closure. Form closure is structural stability intrinsic to the joint. Force closure is stability from muscles compressing across the joint. So it's a little bit of a keystone concept along with the muscular forces across it. So Bengt Sturesen in Sweden, the guy who did the RSA studies, had these series of patients, most of them postpartum women who had extreme pain after delivery and just never got better. And he put external fixator frames on them and was able to demonstrate that they were able to go from not being able to walk to being able to walk pretty well. He measured what kind of forces he applied, how it shifted the pelvis around a little bit, and the bottom line was that, let's see, I want to go back. The bottom line was that it actually worked, and then he went on to fuse these patients. All right, so what kind of loads go across the SI joint? So this is one study, and there have been some others. I think this number is actually a little low, and the numbers have been as high as 750 newtons across the SI joint. So that's a lot of force. And if you think about it, all of the body weight has to go through the SI joint, and when we're in single limb stance, you're supporting your whole body weight, and it's actually more than body weight because the muscular contraction that is used to stabilize your stance generates more force than body weight. All right, what nerve innervates the SI joint? Great question. So before I really got started in this space, I had never heard of Hilton's Law. I thought it was maybe if I stayed at a Hilton hotel, the next day was going to be good or something like that. But what Hilton's Law says is that if a nerve crosses a joint, it can innervate it. Well, there's a whole lot of nerves that cross the SI joint, and that makes that a little more confusing and difficult. And in fact, I've had people who've had florid, radicular, dermatomal pain pattern because the L5 and S1 nerves go right across the anterior portion of the joint. And so if you have cytokines being generated there and they leak out into the neighborhood, they're getting the L5 or the S1 nerve root. So that's the pathomechanics of how that can happen. So is the SI joint itself innervated? And the answer is yes, it is. There have been a number of published studies looking at nociceptor and mechanoreceptors within the joint itself. And then Carolina Zasdak from the Netherlands did her PhD thesis on this, and she has some beautiful images that I want to share with you. So she dissected out the anterior capsule of the SI joint, and she dissected the gross nerve fibers going from the lumbosacral plexus to the anterior capsule. And then she did histologic staining showing substance P fibers, CGRP, mechanoreceptors, and unmyelinated nerve fibers going into that anterior joint capsule, all of which are well known to be pathways for pain transmission to the brain. So these are just some more of those histology slides. And then she did the same thing on the cartilaginous surface and demonstrated these same nerve fibers within the cartilage as well. So not only is the anterior capsule innervated, but the cartilage in the joint itself is innervated. So the basic science summary is that the joint moves a little bit, and it's innervated with pain-sensing nerve fibers. So why wouldn't it hurt? So now the question is, can you reliably diagnose it by physical exam or other modalities? So if you're not in this space, this is the most important part of the talk. So these are the exam maneuvers that you need to do in order to make this diagnosis. And all of them differentially torse the SI joint and cause it to move or stress it to see if it reproduces the pain. So the distraction or pelvic gapping test, compression, Patrick or Faber's test, thigh thrust, sacral thrust, and then Gainsland's test, which can be done either with the leg over the side, or my preference is to do it in this fashion. And all of those provide differential torsion across the SI joint. And when you put them all together, if 3 or more of these are positive, you have an 85% positive predictive value that they will respond to a local anesthetic injection. And so 85% positive predictive value is better than a lot of things that we do in spine. And so this has been studied, and it's what's called a clinical diagnostic rule, and it has very high reliability. probably higher than anything else that we examine in the spine. But it's a multi-test survey. No single physical exam test by itself is reliable. But if 3 of 5 are positive, then it is reliable. All right, how about imaging? Well, plain films. No, we have people who have positive findings and no symptoms, and we have people who have no radiographic findings but positive symptoms. CT scan, same story. Gee, sounds like MRI of the spine, where Scott Bowden has made his name on false positive imaging studies over the years, right? And that it's just not helpful. Perhaps in ankylosing spondylitis or spondyloarthropathies, MRI might be helpful. Bone scan, same thing, not helpful. So no imaging modality has good diagnostic value for people with SI joint pain. So sacroiliac joint blocks. So this is really what's been the gold or reference standard to date, but you've got to be sure that you're in the joint, and that if you just do a blind injection, the probability that you're going to get in the joint is probably only about 22%. And then the next piece that we argue quite a bit about is how much pain relief do you need to constitute a positive? So the lower number typically is 50%, and the higher number has typically been 80%. And somewhere in between there is what it's probably about. I also think it's absolutely critical for you to look at the images of the diagnostic block. The needle needs to be in the joint, and preferably on both the AP and lateral plane. And I like to see the contrast, because if it's a blobogram at the bottom of the joint, I don't know what that's numbing up if it just sort of extravasates in here, okay? If the contrast goes through the joint, then I know it's intra-articular. And if I have any doubt, I go to a CT-guided injection, and then I know with 100% certainty the needle is in the joint and the contrast is tracking within the joint. All right, excuse me. So I got mad at NASS because they said the criteria for fusion, you had to have an 80% response to a block. And I said, well, where does that come from? And they said, well, we've done extensive review of this. It's like, there's no literature on that. And so I took a different approach. I took the patients from high-quality clinical trials who responded to surgical treatment, and then we went back and looked at their blocks to try to figure out if they were prognostic. So all of these patients had failed 6 months of non-operative treatment, had 3 of 5 positive physical exam maneuvers, ODI greater than 35, and all of them had at least 50% response, because that was our inclusion criteria for the clinical trials. And what we found is high responders to the blocks and low responders to the blocks didn't really predict outcome after surgery. And so if you had 50 to 75 or 75 to 100, you had a similar probability of a good result with surgical treatment. So I think that this tells us that having to have an 80% response to a block is probably not appropriate. There are things that I can't tell you, though. What if they have less than a 50% response to the block? I don't know, because we didn't operate on them. All right, so now let's talk about some clinical trial data. Now, these are on triangular titanium rods. That's where most of the data is. I'll show you at least one study of an alternative strategy, but let's walk through these. So Insight is a US-based randomized controlled trial, 2-to-1 randomization, operative versus non-operative treatment. So it's a prospective study, outcome variables, visual analog pain scale, secondary outcome variables, ODI, EQ5D, SF36, and radiographic. So here's the clinical enrollment strategy. At 6 months, we allowed the patients to cross over. We thought that this was the only way to do this ethically and get these patients to agree to enroll in the trial. And here's the money or take-home slide on this. We saw clinically significant and statistically very significant visual analog pain response and ODI improvement. We do not take these patients down to 0. Typically, their ODIs are in the 50 to 60 range, and we cut it in half. And so they still end up with a 25 to a 30 ODI, but it's much better than a 60 ODI. The visual analog pain scales were very significant, and the crossover patients, once they crossed over, they looked exactly like the patients randomized to surgical treatment initially. Modest decrease in opioid use. At the time we designed this trial, it wasn't as the focus on opioids wasn't where it is today. Safety-wise, 2 issues that came up in the surgical cohort, 1 implant malposition with radicular symptoms, and then 1 undisplaced fracture in the ilium, which subsequently went on to heal. IMEA, same trial design done in Europe. This was a 1-to-1 randomization. We learned some things in the first clinical trial and applied it to the second clinical trial, and the data looks exactly the same. It can in fact be superimposed, and I'll show you that in a minute. Same kinds of findings. Again, similar response after crossover. They added a couple of things that were a little more objective. So this is a patient self-report of ability to walk. And so we saw marked improvement in ability to walk in the patients after surgery. SciFi, a U.S. study for those surgeons who didn't have equipoise to randomize. So it's a prospective cohort study. And guess what? The response patterns of visual analog pain scale and ODI look just like the RCT. So we then pooled this data. And you see that the graphs are almost superimposed, and so consistent effect size, consistent effect direction, suggesting that this is probably a real effect. And so we did a pooled analysis, which now gave us the ability to have enough patients to look at things like smoking and opioids. And smokers still improve. They don't improve quite as much as non-smokers. And opioid-tolerant patients still improve, just not quite as much as opioid-naive patients. All right, Lois, long-term follow-up of some of these prospective studies, trying to go out to 5 years, and this manuscript is currently in review, and that it shows that the benefit seems to be durable out to 5 years, that we don't really see a big taper off. If they heal and if they are stable, they seem to maintain that over time. Long-term opioid reduction as part of the LOA study. So we're seeing that we still have patients using opioids, but it's significantly less than preoperatively. Sally, so there is a newer implant, which is a 3D printed implant, and the question for this one is that equivalent to the other implant? And the early data through 6 months looks like, I can't tell you that it's better, but I can tell you that it's not worse. And then some sample scans. So this is the 3D printed implant, and it looks like we got bony bridging there, and then the same patient, the original solid titanium implant. So Vicente Vanaclocha in Spain, based on patients' insurance, they either were able to get physical therapy only, radiofrequency ablation, or surgical treatment. So it's not randomized. So the cohorts aren't exactly equal, but it's a similar patient population. And that he looked at these patients and out to 6 years, and that the patients who only got non-operative management actually, in fact, got worse and a higher opioid use rate. The patients who got radiofrequency denervation got better for a little while, but then regressed to look very similar to the non-surgical treatment patients. And then the fusion patients got better and appeared to maintain the benefit out to 6 years. Same thing with ODI findings. So the first one was VAS and then ODI. And then looking at their working at baseline versus at last follow-up, more fusion patients were working at follow-up than at initiation, whereas in the other categories they went down. Also reduced opioid use significantly in the surgically treated patients and increased opioid use in the non-surgically treated patients. How are we doing surgically as a cohort in the United States? And so when it first came out, like anything, we probably weren't as good technically as we are now, and we've gotten better. And so it looks like we're trending towards better survivability of the implants. This is the newer implant looking at its ability to avoid needing revision. And there's not a statistical difference in that graph. It's trending that way. With time, we'll see if that makes a difference or not. How about healthcare economics? The bottom line is it's similarly cost effective to total hip and total knee replacement. So that's actually a pretty compelling story. How about other strategies? So I only am aware of one additional 2-year prospective multi-center study with an alternative strategy, and this is a threaded cage done from a posterior approach in what's called distraction arthrodesis, and similar effect sizes. I don't know this data as well as I know the other data, but it suggests that there is efficacy in it, and like everything, if you know what you're doing and do it well, it can work. If you don't know what you're doing and you do it poorly, I'm pretty sure it won't work. So remaining clinical challenges, how do you select these patients? What do you do for people who don't necessarily have 3 positive physical exam findings? I'm currently not operating on those patients. What about those patients with a negative physical exam and positive injection? I think that's usually there's something else going on. And patients with long spinal fusions and sagittal imbalance, fix the sagittal imbalance before you fix the SI joint. All right, so summary of the clinical data to date. It's a common problem. RFA, only short-term benefit. Multiple studies suggesting benefit from surgical treatment. It has clinically significant pain reduction, clinically significant ODI improvement, durable results through 6 years, decreased opioid use, higher return to work rate than pre-op, and it's as cost-effective as a total knee. So that's a pretty compelling story. I'm going to blow through the biomechanics fairly quickly, but these next 2 slides, I think, are critical to our understanding about the whole concept of adjacent segment degeneration. So if you fuse the SI joint, the relative increased stress on the spine is in the 2 to 4% range. In the hip, it's around 5%. However, if you fuse the spine, if you fuse L5-S1, the increased stress on the SI joint goes up by 50%. If you fuse L4 to the sacrum, it goes up by 168%. And so that tells you why that prevalence is higher in people who've had spine fusions versus those who haven't.
Can you go back to that again?
Yes, absolutely.
Can you explain the implications of that? So,
yeah.
Meaning, like, say, for instance, you had a long construct that ends at L5-S1, right?
So the question is, should we do pelvic fixation and concomitant SI fusion every time we're fusing to the sacrum? And the answer is, I don't know. There is emerging data to suggest it's a bigger problem than we've realized because we haven't looked for it. We've had so many problems with PJK that we've sort of ignored the foundation. As we get better at PJK, we're going to start looking at the foundation and finding the foundation is not perfect. What is the plan going forward? Well, we're looking at starting an RCT about concomitant SI fusion when we're doing S2AI screws, but we haven't started that yet. And so there's not data yet. There's data to suggest it's a problem. There's data to suggest biomechanically it's a good idea, but there's not yet compelling clinical data that we should all be adopting it.
What I'm not understanding, though, is like, so you're saying if L5 to S1 is fused, and there's 52% increased loading on the SI joint. If it's L4 through S1, it's 168. But if you then fuse the SI joint, it's only 5% on the hip.
No, that's not correct. Yeah, so if you fuse the SI joint, because it doesn't move very much.
Yeah.
Right, and so that's my presumption. And so it doesn't transfer a lot of additional stress to the other segments.
Got it.
Whereas the spine moves a lot, and you're doing a lot of additional stress transfer.
Got it.
Does that make sense?
Yeah.
Okay. All right. So there's some advantages of triangles versus screws in rotation. The implant is designed to far exceed the fatigue load failure. It substantially decreases motion, doesn't completely eliminate it, but decreases it. There are patterns of implantation that seem to work better, and the understanding of the bone in the sacrum is critical, so that the bone in the S1 vertebral body is the best bone, and the worst bone is in the sacroiliac. And so if you only put it in there, don't expect it to have much purchase. And then that's been looked at in a number of different studies. We looked at a study doing opportunistic bone mineral density, showed the same thing. And you can get a sense of this just by looking at your CT scan, drawing a circle over the area and looking at the Hounsfield units. And if your Hounsfield units are less than 100, your purchase is probably not going to be very good. And so we did correlations with age and sex on that. Transarticular implants seem to be more stable than posterior directed implants.
Can you go back to that last one too? Which implant pattern is the most effective biomechanically.
Right. So let me summarize all of the implant data. Your cephalad implant is the most critical. It needs to extend into the S1 body medial to the ventral foramen of S1. And that will give you the biggest impact. 3 are better than 2. Curvilinear rather than linear are better.
Got it.
All right, and in the interest of time, I'm going to blow through a couple of these, and it just shows the transarticular is better than a posterior approach, and then just a couple of representative examples of the different approaches and the bone densities. And what I want, and then this is the biomechanical study on the hip loading, showing it doesn't make a lot of difference. So let's walk through what does a surgical procedure look like. So here is a normal appearing sacrum, and we're going to focus on this a little bit. And normal appearing means that when we look here, there's a straight line across the top. So there's not a transitional vertebra and there's not an upslope, and I'll show you that in a little more detail in subsequent slides. What it looks like on the lateral. Okay, so this patient underwent the workup. They had a CT-guided injection. It gave them complete relief of the pain. And so I do these procedures with image-guided technology, and it's the most minimally invasive thing that I do. The rest of the stuff I do is usually maximally invasive. And so putting in the first pin, then putting it, I navigate the pin across, I check it under fluoroscopy.
The reference is on the PSIS on the contralateral
side? Yes. And then there's a drill and a broach, and then you impact it, and then I check to see if it's flush with the outer table of the ilium with an iliac oblique view. Then second pin, and I like to do it in this strategy in a normal sacrum, and then same procedure, and then check it. And then the third pin, now we're at S2, and same concept. And then I personally do my inlet, outlet, laterals, and then I do a check spin on every patient. I would critique myself a little bit on this one and say, this one's a little more posterior. I'd like it just a touch more anterior. This one I think is fine, and this one I think is fine. And so I critique every one of mine when I look at it. I do this as outpatient. Takes me about 45 to 60 minutes. I lose about 15 cc's of blood. I put in 50 cc's of 0.25% Marcaine with epi along the skin incision and the tracks of the implants. And then I used to do Exparel at the end. My institution has limited Exparel use now, so I can't do that anymore. Ice is important. I do 3 weeks of crutch touch weight bearing. A lot of them get quadratus lumborum spasms, so you need to teach them how to stretch that out beforehand. It'll save a lot of phone calls, and then they come back to clinic at those time frames, and I tell them I expect to see about a 50% ODI improvement. So this is what implantation looks like. And then I want to point out a couple of things. So any pin-based strategy, you have a risk of pin advancement. So when I plan my pin placement strategy, I plan it so if the pin advances, it stays in bone. Because if it stays in bone, we're okay. It's when it goes out the front or through a foramen that bad things happen, okay? And yes, you can see pin advancement happens, all right? And then the implants were okay. We're happy with that. Sacral morphology. This is critical. Please pay attention to this. So transitional vertebra. Everybody here know the Castelvi? Is this new to anybody here? You've seen this schema for grading transitional vertebra. Learn to look for it. A true AP of the sacrum will really help you stay out of trouble with this. And then for the orthopedic trauma, pelvic trauma community, they don't call it transitional vertebra. They call it dysmorphic sacrum. Same concept, same idea. And so we're looking to see, is there that straight across line, or do they have an upslope, or do they have a transitional vertebra? If they have that, do not try to do this procedure under fluoro only unless you are really, really, really familiar with this anatomy, because you'll get yourself in big trouble. Either send it to somebody else or do it with navigation. And these are, again, the clues. They're subtle clues, but they give you a clue about this is a danger zone. And the problem is that you don't see that anterior line to judge your guidance in your pen. And this is the concept that if you try to put a straight across implant in at this level, you are going to go through the neuroforamen. and that's a bad thing. So the concept is that you've got to change your trajectories, and conveniently, Radascuian scoured all of the cadavers for today, and he found the one specimen with a transitional segment, and that's the one that I get to do the demo on. So, so that's important to know. But when you have this transitional morphology, you usually have a large S2 channel to go through. And so for the trauma pelvis guys, this is what they're looking to do. They're looking to put through and through screws if they can, and in normal morphology, they usually can. In the dysmorphic sacrum, they got to do a different strategy. All right, so again, normal morphology, this is what the CT scan looks like at S1. You got a big channel to go through and through, not a problem. S2 looks good, big channel through and through. So we just do our usual implantation strategy, and then the check spin on the implants, and looks good. All right, what do we see here? Who wants to classify that in a Castelvi-Chan fashion for me? That's a Castelvi-Chan 2A, which is probably the most common symptomatic one, has a unilateral false articulation. This is, back to showing my age, but the Space Family Robinson, danger, 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 Will Robinson. Anybody here know what I'm talking about with that? Okay. All right. So anyway, you see this is trouble. So know it even before you get started on it. All right, and so you look at this, and the anatomy is just all messed up from the side. You're going to have trouble doing this fluoro-guided, and this is what it looks like on CT. And not only is it not a straight across quarter, it's actually aimed posteriorly directly at the neural canal, and that if you put your implant in wrong, you're going to cause some problems. But there is a large S2 through and through quarter. And so this patient, I could only get 2 implants in, and it was more challenging. Okay, more subtle dysmorphic sacrum. So here it's the upslope, okay? So it's that upslope that's gonna get us in trouble. So how do we spot that? So this is, again, what the CT scan on this patient looks like. And if you try to go straight across here, boom, boom. All right, you're going to hit the S1 nerve roots and not do good things. And then again, a large S2. So when you got this dysmorphic sacrum, you're going to have a large S2 quarter. And so again, what that looks like. And I have not done this person's surgery yet. And so just the correlation. And then every once in a while, we see this really weird sort of accessory articulation right there. We don't really know what that means. It's probably like a buttressing osteophyte, but it's just an interesting thing that shows up every once in a while. Okay, and then for my colleagues who were wondering about the screws, so this is a tumor patient, but this is the kind of thing that I like to do for sacral insufficiency fracture or stabilization. So that's what a through and through screw would look like. Revisions. So you've heard me say, don't put anything in you're not prepared to take out. I'm going to blow through this quickly because I'm over time. And so my current revision strategies, take out the implants, bone graft, and try to put through and through screws across. I drop a Medtronic retractor, D-lift retractor in. The reason for that one is because it's got a screw, and I can screw that into the ilium and makes it a little bit easier. And so any lateral access retractor that has a screw that you can screw down will work similarly. And so that allows me to see the implant. I navigate a K-wire in, dilate up, put this retractor in, take out the implant, and it's always well fixed on the iliac side, and the failure is always on the sacral side because the sacral bone is terrible. And then this was bone grafted, and then a couple of screws across, in this case with washers that worked out. So this is an individual who I did his initial surgery. He was a corrections officer. Standard workup. So this is the blobogram. I don't like that as an imaging study because I don't know what that's numbing up, and that he had differential selective root blocks, MRI of his spine, and then put the implants in good position, good bone stock, and then, so here he is, initial post-op films, then here he is at 6 weeks, and what we're going to see is that there's going to be a halo formation that develops around the tips and that then you get a little sclerotic reactive rind around it, and that's the best sign that you're going to see for loosening. So again, I blocked it to see if that was what relieved his pain. It did. Took those implants out, did an open anterior ilioinguinal approach and autogenous bone grafting. That's a big surgery. He has gone on to heal, and here's the CT scan showing the healing, and he has an ODI of 0. He's I think, my only revision patient who has gone to an ODI of 0, but he is healed and gone back to work normally. So that's a lot of stuff, but I wanted it to be honest and open about it. If you're going to get into something, be prepared for how you can get into trouble and how you can predict it when you're going to have trouble, and then what do you do if it doesn't work? Thank you.
Great talk. Larry, question.
The other side. How often,
Use your microphone is what they told me to say to you.
how often
Good
does
question.
moving, like I don't do many of these, but one of the population I have of referrals from is from Marfan's and rheumatoid and Ehlers-Danlos kids.
Yeah.
How often does the other side go bad, and when, and like what are your thoughts about just doing both at the same time? et
Yeah,
cetera?
so my problem with doing both at the same time is how are you touch weight bearing on one extremity with both at the same time?
Do you have to be touch weight bearing?
So that's a matter of debate.
Yeah.
I think it's the best way to try to get it to heal, because when they loosen, it's that nutation, torsion, and it's that getting that initial bone stability. Once you get that initial bone stability, the late revision rate is like 0. But the acute loosening is where the problem will occur. So how do you get it to heal best? So in my hands, in my patients, not just Marfan's, but all comers, about 1/3 end up needing bilateral.
How many of you have actually done these before, the SI bone or SI joint fusions? I mean, so like the surgeons that have done these, I mean, it's like ridiculously simple. I'm saying, like, once you actually, anatomically, you have to be really careful about where you place these. But once you do it, like, right? I mean, like, they're literally, it's like you said, it's like a 30-minute case.
How many here do navigation of some kind? Who doesn't do navigation in their surgery? Okay. So if you do navigation, this is very straightforward.
I can see
if
that.
you don't do navigation, you need to be prepared to look for the pitfalls to try to avoid them.
Yep.
And so there's some people who are really good putting in fluoro-guided iliosacral screws for pelvic trauma. They have no problem with this. If you're not that good at doing that, I would suggest navigation makes it a lot safer and more predictable. And then as you get better at it, maybe you don't need it. But I still do all of mine with navigation.
So I would say that the vast majority of people that do these don't use navigation, but with navigation, how is it compatible with the navigation systems?
Right, so I put the reference pin in the contralateral posterior ilium, obtain my intraoperative 3D images, and then it's a navigated drill guide and place the K-wire. And so what you navigate is the K-wire, and the company has navigated instruments now that are compatible with the Stealth system.
Got it.
And so the brooch, you can actually navigate and see where your implant is going to be.
So what I was going to say is, like, it's once you, and I've only done maybe no more than a dozen total, you know, but so it's not like I have a whole ton of experience. Why, if it's so simple, why don't you think that this is caught on yet amongst spine surgeons?
So a couple of reasons. Number one, if you don't look for it, you'll never see it. Number two, very few people were trained how to look for SI joint pain. Number three, it doesn't pay that great. And so it's sort of like, do you look for it, and are you willing to try to treat patients who hurt? And there are people who hurt that you don't want to try to treat, and there are people who hurt that you do want to try to treat. So it's, what is your filter for what you're willing to take on or not take on? Like, do you do revision surgery in patients? Do you do revision of people who have stems and pumps? Do you do fusions on smokers? You know, it's all of those kinds of questions. But I think the first thing is, if you never look for it, you'll never see it.
So a couple final questions. Do you, and I don't know the answer to this question, but you brought up the whole issue with, like, transitional syndrome. Is there any relation to Bertolotti's? with the SI joint?
Yeah. So absolutely. So there's intriguing emerging information from finite element modeling trying to understand how this all behaves. And not only is Bertolotti's an issue, but limb length discrepancy is an issue. And that limb length discrepancy can increase loading on the SI joint by up to 400%. And so there are a lot of things that affect the SI joint. And if you think about it, how do you transfer the load from the thorax to the lower extremities? So it's obviously got to go through the pelvis, so it's obviously got to get into the pelvis, and it's obviously got to go across the SI joint into the acetabulum of the hip. And that anything that alters that pathway could affect how it behaves. So transitional vertebra, fusions, et cetera, all affect that pathway.
So the last question is, and I told you I would ask you this question. So I was sort of looking around in the exhibit area, and I saw that in a model that there was actually one of these devices in an S2AI type of construct, right? And from what I understand, you're working on this. So can you just tell us a little bit about that?
Yeah, so we don't have meaningful clinical data. It's FDA approved on-label use to do it that way. So if you choose to do it, you can. There is compelling data that the patients that we fuse to the pelvis have more symptoms than we want to admit to, and that anybody who's put in iliac screws with conventional offset connectors knows how prominent they are, and that you've had to take some of those out if you've actually followed your patients, and they can be quite prominent. So S2AI screws were an advance by lowering the profile and improving the purchase and pull-out strength by crossing more cortices, but you are violating an unfused joint, whereas before we were crossing but not violating an unfused joint. And so some people have the potential to hurt when we do that. How often? The data ranges from 0 to 40%. I think that there are a myriad of factors that play, the biggest one being sagittal alignment. And that so I have a flagpole analogy. So if you have a flagpole that's perfectly perpendicular, you got guy wires going to it. Those guy wires carry equal load. If you got the Iwo Jima flag, now only one guy wire can carry load. And that if you're standing in positive sagittal imbalance, you have constant perpetual overpull of the erector spinae muscle, which all insert on the posterior pelvis. And so if they have posterior pelvic pain because of sagittal imbalance, it's from muscle overpull, not from necessarily intrinsic disease within the SI joint. So if you don't fix the sagittal alignment, I don't care what you do to the SI joint, they're still going to hurt. So that's the most common thing that I see of people who've been fused in a malaligned position sent to me, and they've had an SI block, which is positive, but their physical exam is negative. And so I fix their sagittal alignment first. And should we be doing simultaneous fusion? Maybe, maybe not. That's an item that we're going to study, but I don't have any clinical data to give to you yet. I got lots of biomechanical data, but no clinical data yet.
So what's your general thought, though? Because the way I saw it over there, it looked like it's being approached from an S2AI approach, but couldn't you do it the opposite way, where you could actually just fuse it just by standard approach here for SI joint?
Yes, you can. We don't know which will be better. If you do it with if you're already open and you're there, it probably adds 5 to 7 minutes to the procedure, so not a high problem. If you've ever had to, so I've had a number of people who've had SI fusions that I've then had to go to the pelvis, and trying to get pelvic fixation around those implants is challenging. So it's easier to do the pelvic fixation first and then put the implants around it. You probably won't get 3, probably only will get 2. And is that enough, and how are they going to do? Too early to tell. Biomechanically, there's a compelling story behind it. Clinically, we don't have data yet. And so if you pay attention to your patients who you're doing pelvic fixation on, you will see that a number of them do in fact have pain in this area, and we're trying to figure out and be honest about what should we do to try to fix these. And this is a strategy that we think has a lot of promise, but it's too early to tell.
Great. Thank you so much, Dave. Really appreciate it.